decreased interaction of social from family members for past 4 days, history of forgetfulness and sleep disturbance, a history of hearing unusual voices at night, and history of decreased appetite and reduced activity. She was also giving history of hair loss and history of menstrual irregularities. There was no history of any excessive sweating, palpitations of cold and intolerance. There was no history of weight gain, constipation, or hoarseness of voice. No history of fever, rash, joint pain. No history of any abnormal movements. No history of head injury, substance use, seizures. There was no history of any active suicidal ideation or related.
display material.
Antenatal history, it was uneventful. Birth history also was uneventful.
At least we can.
Past history, she is known case of hypothyroidism since 6 years of age, and she was started on thyroid and 100 microgram, and she discontinued the medication for past 1 year onwards. Developmental history, she attained all milestones appropriate for her age, and she discontinued her schools from 6th standard onwards, and frequent school absenteeism was present. Immunization history, she was immunized till 10 years of age according to National Immunization Schedule. Menstrual history, she attained menarche at 30 years of age, 8 to 10 days in 45 days cycle with passage of clothes, and history of dysmenorrhea was also present. She is the first born out of non-consanguineous marriage. There was no history of any thyroid disorders or neuropsychiatric disease in the family. Dietary history, she is having a calorie intake of 1,800 kilocalorie with a deficit of 120 kilocalorie. She is having a protein intake of 58 grams with a deficit of 2 grams. Socioeconomic history, according to modified Glucosonic scale, she belonged to lower middle class family. Somebody 16-year-old girl was born out of non-consanguineous marriage. She was a known case of hypothyroidism on poor compliance of thyroxine. It was not attending school and immunized up to 10 years of age. Presented with complaints of decreased social interaction, auditory hallucination with difficulty in sleeping, and menstrual irregularities. Could be hypothyroid-induced psychosis was suspected in this trend. General examination. The child was conscious, oriented to time-place person, and pallor was present. There was no icterus, signs of clubbing, edema, or lymphadenopathy. Vitals, her pulse rate was 90 per minute, regular in rhythm, normal volume and character, no radial or radiofemoral carriage. Peripheral pulses were well felt. BP was 180/70 mmHg at 90th centile, which was measured from right arm and sitting position using age-appropriate cuff. Respiratory rate 20 per minute, right abdominal type. Saturation was maintaining 98% at home. Temperature 98.5 degree Fahrenheit and CRT less than 3 seconds. Anthropometry, weight was coming in the score of 0 to -1 and length at 0 and BMI 0 to -1. Interpretation of normal. Head to toe examination, eyes, ears, eyes, nose were normal. Skin, BCG scar was present. Neck, there was a 4 to 3 centimeter swelling over the anterior aspect of neck. Mouth, oral cavity, throat appears normal. Genitalia, female phenotype, SMR stage, grade 5. Local examination, neck inspection, there was a uniform, well-defined swelling over the anterior aspect of neck, which moves with deglutition, and skin of the swelling appears to be normal. There was no scar or dilated veins. Palpation, no warmth or tenderness. Trachea was central in position, 4 to 3 centimeter uniform swelling, which was soft and consistency with smooth surface, well-defined borders over the anterior aspect of neck. There was no fixity to underlying structures and carotid pulsations were well. Auscultation, there was no bruit heard over this swelling. System examination, CNS, higher mental function. She was alert, conscious, and she was oriented to time-place person. She was maintaining eye contact, and memory disturbances, recent and immediate memory was affected. Intelligence, normal IQ, speech, she comprehends well to speech, but she was having slow speech. Sleep disturbances were present, and auditory hallucinations were also present. Cranial nerve examination was done, it was normal. Motor system, there was no atrophy in the bulk, and bilaterally tone was normal in all 4 limbs, and power was also 5/5 in both upper and lower limbs. The reflexes were also present and she was having plantar plexus bilateral. Sensory system was intact. She was able to perceive sensations equally in bilateral. Cerebellar signs, she was able, it was normal. She was able to do finger nose and finger test. She was able to do shield chin, tandem walking. There was no signs of meningeal irritation. Spinal frame was found. Other systems, respiratory system, there was bilateral air entry was there, normal vesicular breath sounds, no added sounds. Central CVS, S1, S2 plus, no murmur, and per abdomen, which was soft, bowel sounds were heard, no, then it was not tactile, no phenomenon. Investigation, CBC was done and PLC of 8,400, HP of 8.2, hematocrit was 24.9, platelet 2.12, which peripheral mutual normocytic normochromic anemia, MCV of 85, and stage of 28. Thyroid profile, her FT4 at the time of admission was 0.58 and TSH was 422. So we have done an 90 TPO level, which came out to be 143 positive for the patient. And we have started her on thyroid hormone 200 microgram, following which during the course of hospital stay, we have repeated one more. TSH has come down to 262.60, and after 1 month during the review time, her TSH has come down to 95.9. USG thyroid done at the time of admission was normal. To rule out a secondary organic causes of psychosis, PTH was done. PTH calcium phosphorus workup was done, which was normal. Vitamin D was 11.2. ANA workup done was negative. LFT and RFT was done with the normal. Treatment, she was started on thyronol 200 microgram at 4 microgram per kg and was equal to 100 microgram and after 2 weeks. And vitamin D supplementation were also given 6,000 international units weekly for 6 weeks. And psychiatric opinion was obtained, and she was diagnosed to have psychosis secondary to hypothyroidism, and she was started on benzodiazepine. Diagnosis: a 16-year-old girl, a known case of hypothyroidism on poor compliance with oral thyroxine. She presented complaints of neuropsychiatric symptoms and no other secondary causes. Probably psychosis is secondary to autoimmune or Hashimoto thyroiditis. Differential diagnosis: metabolic, Wilson's disease, uremia, hypoparathyroidism, electrolyte disturbances, intoxication, drugs, lead, mercury, cocaine, cannabis, immune-mediated SLE, Sjogren's syndrome, autoimmune encephalitis, CNS infection, stroke, tumor, temporal lobe. Autoimmune thyroiditis or Hashimoto thyroiditis is the most common cause of acute hypothyroidism in children and adolescents. It's the most common type of autoimmune thyroiditis is chronic lymphocytic thyroiditis. Etiology: it is inherited susceptibility in genes HLA, DR4, and DR5. Circulating autoantibodies to thyroperoxidase and thyroglobulins in this. Family clusters are common, and incidence in sibling or parents of affected children, they can have a 25% of incidence, and it is associated with other autoimmune disorders having 10% in APS1 syndrome. APS1 is autoimmune polyenterograninopathy and candidiasis ectodermal dysplasia. APS2, the child will be having type 1 diabetes, autoimmune primary adrenal insufficiency, polycythemia anemia, vitiligo, and alopecia. Clinical features: it is 4 to 6 times more common in females than males, and it is more common after 6 years of age, and reaches peak incidence during adolescence. The goiter, it will be due to thyroid inflammation and fibrosis. The thyroid gland will be diffusely enlarged and firm, not dense. Most of the cases will be euthyroid, but some present as hypothyroid, and they will be having growth retardation. Hypothyroidism features: they will be having weight gain, cold intolerance, they will be having fatigue and shortness of breath. Neurosensory system, they will be having hoarseness of voice, decreased taste and vision. Neurologic and psychiatric system, they can have impaired memory, paresthesia, mood impairment. GI, they can have constipation. Endocrinology part: infertility or subfertility, menstrual disturbance, calaturia. Musculoskeletal system, they can have muscle weakness, muscle cramps, and hematology, they can have bleeding, fatigue. Skin, they can have dry skin, hair loss. Hashimotosis: in some cases, autoimmune thyroiditis, they can present as transient thyroiditis due to autoimmune thyroid tissue destruction, that is Hashimotosis. So this case, they can present with tremulousness, irritability, increased sweating, hyperactivity, and ophthalmopathy is very rare in such conditions. Investigation, thyroid function test will be usually normal. In some cases, serum PSH can be elevated. It can be, and where the T4 will be normal in subclinical cases, and over cases it will be low T4. And measurement of thyroid autoantibodies is useful in diagnosis, but they do not correlate with thyroid function, like antibodies against thyroglobulin and EPO antibodies. Imaging thyroid scintigraphy, it reveals decreased radioisotope uptake, and they will be having a patchy and regular appearance. Thyroid ultrasound USG will be showing a diffuse heterogeneous and hypogynous. Treatment in overt hypothyroidism, oral levothyroxine dose can be started based on the weight of the child or body surface area, and it should be continued lifelong. Usually, will be starting at 100 microgram per meter square body surface area. In 1 to 3 years of age, 4 to 6 microgram per kg with body weight, and 3 to 10 years, 3 to 5 microgram per kg, 10 to 16 years, 2 to 4 microgram per kg. Further dose adjustment are adjusted to maintain TSH and total T4 and T4 and rate. And autoimmune thyroiditis is usually self-limited. There is no need, and need for continued therapy has to be re-evaluated periodically. Lisa.
Nice presentation. Any questions?
Dr. Devika,
Yes, ma'am.
you said in your examination that CNS examination was normal.
Normal. Intelligence normal. Everything. Even this.
What abnormalities can you expect?
Chettinad.
Okay. Can you think of some other abnormalities that you might expect?
In a motor system, she can have a pseudo hypertrophy of the calf muscles.
Okay. So you're going into the muscular. What is that called? When will you have pseudo hypertrophy?
It is called, in moderate to severe cases of hypothyroidism, there is a condition called Cocker-Debbie syndrome. So that condition you can have a pseudo hypertrophy of the calf muscles.
Okay. You're thinking of Cocker-Debbie syndrome. But otherwise, CNS, how was the intelligence like in this child?
She was able.
How was the scholastic performance?
Ma'am, her scholastic performance was since she has discontinued her education after sixth standard, she was able to do basic mathematics skills and all. She was able to comprehend.
Okay, thank you.
Audible, sir?
Good.
Actually, it's a good presentation,
I'm
sir.
going not no. She told us. She's going in towns for meeting.
Am I audible?
Yeah.
Okay.
Any questions from the forum, sir?
Sir, audible, sir?
Yes, sir. Yes.
Okay, sir. Sir, nice presentation. I think it's very not so common we see such psychosis with profound hypothyroidism. Few questions was there. So one is usually in acquired hypothyroidism, we build in the thyroxine slowly. In congenital hypothyroidism, we hit hard, so we start with a higher dose to start with, and then we titrate down. Whereas in acquired, we start slowly to and reach up on the higher because of the side effects. Thyroxine can have side effects of hyperactiveness and tremulousness, sleeplessness. So already child has some psychotic, so it might add up when we start with a higher dose. So that was one. And second, I think maybe Dr. Ramya can explain about this differentiation between what caused this features. Do you want to attribute it to Hashimoto's or hypothyroidism as such?
Good afternoon. A good presentation. I just want to know that, see, basically Hashimoto encephalopathy, as you said, thyroid function test will be normal, or even it can be hyperthyroid also. So we tend to say hypothyroid encephalopathy only with respect to the titers of antibodies. So in your case, the antibodies were almost somewhere around 100. So do you still feel it explains the encephalopathy, or should we still think about other DDs? Though there was a significant improvement in with thyroxine supplement, I just want to ask you, what is exactly hashimoto-encephalopathy? How it is actually defined?
Since there is a, they have for this age of female child, they have ruled out other autoimmune causes and other secondary causes also. So, mostly this has developed secondary to the hypothyroidism, and since it has the age and the presentation all is associated with the autoimmune thyroiditis, so we probably took it as secondary to Hashimoto's or Hashimoto's thyroidism.
The only thing literature says is predominantly the hashimoto-encephalopathy is because of the antibodies itself rather than the thyroid status. It is because of the multiple mechanism proposed secondary to autoantibodies. So ideally, TFT can be anywhere, and the ideal treatment of choice is steroids. However, in this case, the anti-TPO is not that much elevated. Good that actually kid improved with thyroxine supplement. That's our take point.
So I think maybe we can have it as two categories, sir. So one is Hashimoto's encephalopathy, where it is the antibody that is causing the encephalopathy, and steroid is the treatment option. The child will respond with steroids. Maybe the second option is myxedema madness concept, where hypothyroidism as such can cause this problem, and child responded to the thyroid supplementation. So rather than the Hashimoto's, it is the hypothyroidism itself causing the psychosis, and that's why the child responded with thyroxine. So that two entity, I think you can have a take-home point. So Hashimoto's is due to antibody induced, and steroid it responds to steroid. And hypothyroidism itself, as in myxedema, where we might not have other signs sometimes, only the thyroxine will be low, and we started with thyroxine and started on the lower side rather than on the higher side. Just because of the psychosis, we should not be alarmed. Start it on the lower side and build it up. Maybe for the psychosis, we can give the antipsychotics. So that's the take. Okay. But, yeah.
Can I see the slide on differential diagnosis, please? Yeah, huh? No, actually, primary psychosis should also be kept in mind. Adolescence is the age when primary psychosis also manifests. These are all secondary causes. At this age, you can easily get primary psychosis also. I think you can add that to that. That's all. Thank you.
Thank you, sir. Thank
Next presentation from the SR Medical College. The presenter, Dr. Vandan Nampu, and the moderator, Dr. Ramya from Robert Wilson.
Good morning, everyone. This is Harsha from SR Medical College. My moderator is Dr. Ramya. Panelist is Dr. Robert Wilson, sir. Introduction. This is an 8-year-old male child, Sam Alvin, hailing from Chengalpattu. Informant is mother and reliability is good. His chief complaints were double vision for 4 days, head tilt towards the left side for 4 days, and deviation of the angle of the mouth to the left side for 1 day. History of presenting illness. An 8-year-old child who was apparently normal 4 days back was brought with history of double vision, which is acute in onset, intermittent, non-increasing or decreasing with specific gaze, and of the same intensity for the past 4 days. He could not mention the improvement of the double vision with closing either of the eyes. History of left-sided deviation of the mouth associated with incomplete closure of the right eyelid and a burning sensation. History of difficulty in holding food in the right side of the face associated with drooling of the saliva. History of decreased taste sensation for a day. Negative history. No history of decreased vision, eye pain, and eye swelling to rule out local eye pathologies. No history of reduced smell, reduced hearing, tinnitus, regurgitation of the food, slurred speech, or reduced sensation over the face to rule out any other cranial nerve involvement. Able to lift hands above a head, comb hair, button and unbutton shirt, use spoon or pen, get up from supine position, turning supine to prone, able to walk without gait disturbance, able to get up from chair and holding chapel. These are all to rule out any motor system involvement. Able to perceive hot or cold while taking a bath, able to feel clothes over the body, no abnormal sensation. These are all to rule out any sensory system involvement. Um, Able to no history of swaying or tremors while walking, no history of abnormal movement of the eyeballs. This is to rule out any cerebellar involvement. Bowel and bladder, there's no urinary retention or bowel incontinence. This is to rule out any spinal involvement. No history of flushing, sweating, giddiness, palpitation, chest pain and breathing difficulty. This is basically to rule out any spinal involvement. No history of trauma, fever, seizures, altered sensorium in ingestion of drugs or toxins. Past history. No history of fever in the past, no history of trauma, chronic illness, TB, or previous hospitalization. No history of similar transient neurological deficits. This is for any relapsing or remitting course of the disease. Treatment history, the child is not on any medication. Antenatal and perinatal history is normal. Family history, non-consanguineous marriage, a single child. Mother has a history of frontal meningioma. She was diagnosed at 35 years of age with a complaint. She presented with the complaints of headache and occasional dizziness. MRI showed no progression of disease. So the patient is currently on symptomatic management. Immunization history, immunized up to date. Development history normal. Economical, socio-economic history, lower middle class. And in nutrition, mixed diet. The child excess kilocalories history intake is present and junk food consumption is present. Summary. An 80-year-old male child, developmentally normal and adequately immunized, came with complaints of acute onset of double vision and deviation of the angle of the mouth towards the left, associated with difficulty in closing the right eye completely and facial asymmetry. This is not preceded or associated with fever, altered sensorium, or vomiting. No evidence of other cranial nerve, motor system, or sensory, cerebellum, autonomic, or cardiac involvement. There is a history of static CNS malignancy in the mother. Based on history, we can conclude that there is seventh nerve, right seventh nerve palsy, and probable sixth nerve or third, fourth, or sixth, that is the extraocular innervation nerve palsy. So so we can conclude that based on this, there can be a sixth, because the nuclei of the sixth and seventh nerve are at a close proximity in the pons. So element, so one possibility is element sixth nerve and seventh nerve palsy, which is pointing towards localization to the dorsal pons. So based on the history, the differential diagnosis, first differential I would like to consider will be demyelinating disorders, because based on the age of the child and acute or subacute presentation and involvement of the cranial nerves. So demyelinating disorders to be considered are clinically isolated syndromes and neuromyelitis optica and multiple sclerosis. But as there are no, as there is no hemiparesis, posterior circulation stroke can be ruled out. And because there is a history of CNS malignancy in the mother, pontine malignancy can also be considered based on the history as differential diagnosis. General physical examination, normal, vital stable, there is no hypertension. Head-to-toe examination, at rest, right esotropia is noted and facial asymmetry is noted, and acanthosis nigricans can be noted. There is binocular diplopia because double vision improved with closing either of the eyes. Anthropometry, the child is coming under obese category. CNS examination, attitude normal and higher mental functions normal. First, second nerves, cranial nerve examination is normal. Visual acuity is 6/6, and no, both, and direct right reflex and indirect right reflex is normal. Fundus is normal. I'd like to show you a video before going for other nerves examination. Because there is on extraocular muscles examination on horizontal gaze, specifically on horizontal gaze, on specifically moving towards the right gaze, there is no movement of the both eyes. But moving towards left gaze, there is no movement in the right eye, but left eye movement is present with nystagmus. I'd like to show you in the video. So first, we are doing the horizontal gaze, that is moving towards the right gaze. So going to the right side, um, so going towards the right side, there is no movement of both the eyes. But going to the left side, there is only movement of the left eye towards the left gaze plus nystagmus. And elevation and depression is not affected. And there is nystagmus. You can see the nystagmus in the left eye here. Nystagmus can be seen in the left eye. In the left side video, I like to show you the examination of the seventh cranial nerve. So on blowing on the right side, there is no there's obliteration of the nasolabial fold, as well as he's not able to completely close the eyes. And on elevation, there is a loss of wrinkling of the right side of forehead. And on smiling, the child, there's a obliteration of the nasolabial fold on the left side, on the right side.
Sorry.
On third, fourth, and sixth nerve examination, at rest there is right esotropia. Pupillary size is normal on the both sides, but on gaze towards the right side, there is no abduction in the right eye and there is no adduction in the left eye. On gaze towards the left, there is no adduction in the right eye, but there is abduction in the left eye along with nystagmus, as seen in the video. Elevation and depression are not affected. On extorsion, it is present. Only extorsion is present along with nystagmus. So based on this, there is no movement. There is no movement of both the eyes on the right gaze. So that is right horizontal palsy. Then there is right internuclear ophthalmoplegia. That is no adduction in one eye with nystagmus of the other eye on the contralateral gaze. So that is right internuclear ophthalmoplegia means no adduction in the right eye with nystagmus of the other eye on the contralateral left gaze. So the fifth nerve is normal, and on the seventh nerve, there is a right side forehead wrinkling is less pronounced, and forehead wrinkling is present in the left side. Bell's phenomenon is present on the right side; it's not in the left. Nasolabial fold obliterated on the right side, and left it is intact. Angle of the mouth deviated to the left side. Holding of the air is less pronounced on the right. Anterior one-third taste is less perceived. 8th, 9th, 10th, 11th, and 12th are normal. Motor system examination is normal. Sensory and cerebellar system is normal. Gait is normal. Meningeal, no meningeal signs. Autonomic system normal. Other systems are normal. Summary. An 8-year-old male child, developmentally normal and adequately immunized, came with complaints of acute onset of double vision, that is binocular diplopia, with deviation of the angle of the mouth towards the left, associated with difficulty in closing of the right eye completely, and facial asymmetry. This is not preceded or associated with fever, altered sensorium, trauma, or vomiting. No evidence of any other cranial nerve, motor system, or sensory, cerebellum, autonomic, or cardiac involvement. History of CNS malignancy, that is meningioma in the mother. On head to foot examination, as we have seen, there is a mild right esotropia at rest, facial asymmetry is present, and anthropometry revealed he comes in the obese category. There is no hypertension or cardiac examination is normal. On extraocular muscles, difficulty in abduction of the right eye and adduction of the left eye on the right gaze. This is right horizontal gaze palsy. Another component is difficulty in adduction of the right eye and nystagmus of the left eye with left gaze palsy. This is right internuclear ophthalmoplegia. But elevation and depression are intact. So based on this, it is 1.5 syndrome. But as the seventh nerve is also involved in the palsy, so 7 plus 1.5 syndrome, that is 8.5 syndrome. So as you can see in the cut section of the pons, there is a close proximity of PPRF, that is paramedian pontine reticular formation, as well as MLF, median longitudinal fasciculus, and the sixth and the seventh nerve. If any lesion occurs in this area, it can lead to the above set condition. So based on this, now the physiology of INO. So So the PPRF gives impulses to the same side sixth nerve. The sixth nerve supplies innervation to the lateral rectus of the same side. Some fibers from the PPRF cross to the other side and supply the MLF. This MLF gives nerve innervation to the third nerve, which supplies the medial rectus of the contralateral side. So, on the contralateral side. So, if any lesion occurs in the MLF, so while MLF, so there won't be adduction of the the contralateral eye. Based on this, if there is a lesion in the sixth PPRF and an MLF, no movement of the same side eye, and because of the contralateral MLF is also involved, there is no adduction in the contralateral eye. So based on this, we can localize it as 1 is attributed to the right horizontal gaze palsy, and 0.5 in the 8.5. 0.5 is attributed to the right internuclear ophthalmoplegia. So this is 1.5 syndrome, along with the seventh, that is the seventh nerve palsy. Combined it forms 8.5 syndrome. So differential diagnosis based on this, my first differential would be demyelinating disorder, because it is a subacute presentation along with the young age. And the ADAM can be ruled out because of the lack of encephalopathy, and brainstem tumors, because mother is a known case of meningioma, just it's a differential diagnosis can be considered. And brainstem stroke, sudden onset, and obesity are the supporting, but it is rare in children, and without any risk factors, we can rule out brainstem stroke. Investigations, all baseline investigations are normal. In MRI, as you can see in this image, this is the area of the pons, and this area, there is a plaque of the disease of the demyelinating occurring in the MRI. So impression, MRI T2 flare, and along with angio and venography was done. Impression was in the posterior aspect of the right hemipons, abducting the fourth ventricle. Possibility of demyelination can be considered. So CSF analysis was normal, CSF culture was normal, and special immunological test that we have done was oligoclonal bands in CSF were positive, and NMO, aquaporin 4, and MOG antibodies in serum as well as CSF were negative. So based on this, we can attribute this disease to pediatric multiple sclerosis. This is 2010 criteria of pediatric multiple sclerosis. As you can see, there is dissemination in space as well as dissemination in time. Dissemination is time means there should be two with the partial resolving, there should be two bouts of the disease should be occurring, as well as dissemination in space. There should be at least 2 of the 4 areas in the central nervous system needs to be involved. This is 2010 criteria, but according to 2024 McDonald's criteria, in dissemination of space, there can be at least 2 of these 5. Previously, there were 4 CNS areas. Now there are 5 CNS areas. So subclinical optic nerve involvement, as well as any of the above given 4 CNS areas can be involved. So to rule this out, we have done VEP to rule out the subclinical lesion. So in visual evoked potential, prolonged P100 latency in the left eye was noted. That is attributing to the left optical nerve demyelinating neuropathy. So this can be given as subclinical lesion, subclinical optic nerve involvement. And OCT and SSPE were normal. And hospital course and management, acute management, we have given pulse corticosteroid therapy, IV therapy for 5 days, and other supportives were given. Response to therapy, patient clinically improved on day 4 of steroids, and adduction of the left eye improved. Facial deviation began to improve. We have discharged the child on oral prednisolone for 4 to 6 weeks. On follow-up, child was followed up after 2 weeks on oral steroid therapy. There was improvement, but it was not complete. Horizontal gaze palsy and facial weakness improved by 50 to 60%. Only 50 to 60%. Hence, we have planned for IVIG and but the parents are yet to decide for the next treatment follow-up. So final diagnosis: inflammatory demyelinating disorder of the CNS presenting as right 8.5 syndrome. Thank you.
Thank you, Doctor. It's a nice presentation. The forum is open for the questions. Thank you. Your name is very difficult to
Robert.
pronounce anyway.
Sir,
Venkata,
Robert,
right?
sir.
Yeah, audible. Am I audible?
Sir, Robert, sir, you are there?
Balaji, sir.
Good afternoon, sir.
Good afternoon, sir. Sir, I congratulate the presenter for the excellent presentation. That was a very nice presentation covering all the aspects, including the anatomical structures. He has made the presentation very well. One or two points I will add. As is pediatric MS is less common only, around 3 to 5% only present in the pediatric age group. The one clinical point which by which we can differentiate demyelination and stroke is stroke will be the onset will be sudden in stroke and the deficit will be maximal at the onset. Whereas in demyelinating disorders, there will be some progression in the initial few days. First day the deficit will start with milder deficit, and over a few days the deficits will keep on increasing, and after some time it will plateau. So by this we can differentiate, but by far the most common cause of INO in general, whether in adults or pediatrics, is demyelinating disorder only. Posterior circulatory stroke is very rare even in adults. So this is a clear-cut case of demyelinating disorder. For every child with lesion in the pons, especially around the fourth ventricle, we have to do NMO antibodies also. Here in this case, it is negative, but because the disease-modifying therapy will vary between MS and neuromyelitis optica. So that was these points I would like to add. This child needs disease-modifying treatment. After IVIG, we will start some form of disease-modifying treatments. That's all from my side, Balaji.
Thank you, sir.
Thank you, sir, for inviting. Am I audible? Am I audible?
Yes, sir. Yes, sir.
Yes, sir. I have a few clarifications. Why don't we start on IVIG first instead of going for methylprednisolone? Does it carry some advantage over methylprednisolone?
Sir?
Yeah.
Sir,
Sir, my question was.
Sir, for
Yes, sir.
the protocol says for all patients with acute demyelination, we must give methylprednisolone, sir, 3 to 5 days. For those who have incomplete response only, we will go for IVIG, sir. Both steroids and IVIG are for acute therapies, sir. Several patients improve with IV methylprednisolone alone, sir.
Request others to mute your mic, please. Yeah, yes, sir, please.
Yes, sir.
So that was a very nice way of presentation, and I hope they have evaluated very nicely before going to imaging. They have come to the conclusion almost like it's a demyelinating disorder without possibly a tumor kind of thing. Well done, sir. Thank you, sir. If there are no further questions for the next presentation from the Kamachi Hospital, by Dr. Deva, the moderator.
Sir, is all the slides visible, sir?
Yes, ma'am. It's visible, ma'am.
Yes.
Good afternoon, everyone. Persistent toe walking, do not forget spine. I am Dr. Deva, a DMD Pediatric Resident of Kamakshi Memorial Hospital. My moderator is Dr. Prahada, Senior Consultant Pediatrician, Dr. Kamakshi Memorial Hospital. And my clinical lead is Dr. Rajeshwari, Fellowship in Clinical Genetics, Chief Consultant Pediatrician and Developmental Neurologist, Dr. Kamakshi Memorial Hospital. Chief complaints: a 3 or 10 months old male child came with complaints of persistent toe walking noticed since 2 years of age. History of presenting illness: the parents noticed persistent toe walking since 2 years of age. He had also had difficulty in getting up from floor, which was progressive, difficulty in bending knees, difficulty in climbing stairs, disturbed sleep for past few months. He was not talking a single meaningful word, and the mother noticed excessive irritability and frequent crying for past few months. Known case of reactive airway disease, known case of autism spectrum disorder on speech therapy and occupational therapy. Toe walking was attributed to autism spectrum. Birth history, spontaneous conception, antenatal period was uneventful, term child, normal vaginal delivery, cried immediately after birth. The birth weight was 2.45 kg, and the child was admitted for fever with rash on day of 8 of life, and was treated with IV antibiotics for 7 days in view of suspected late onset sepsis. Developmental history, motor milestones. The child received head control at 3 months of age, rollover at 6 months of age, sits without support at 7 to 8 months, walks without support at 11 months. Toe walking is noticed since 2 years of age. In case of language milestones, bisyllables is attained at 9 months, and the child calls Amma and Appa at 1 year 2 months of age. But the child then had speech regression. Immunization history, the child was vaccinated up to age. At present, the child has persistent toe walking, has difficulty in climbing stairs, difficulty in getting up from sitting position, and the child is unable to bend the knees while sitting. In case of language, the child cannot speak even a single meaningful word, and the child cannot address father as Appa and mother as Amma, and the child has poor eye contact. On general examination, the child was alert, afebrile, the vitals are stable, the child has insustained eye contact, excessive irritability, and he responds to name call occasionally, and the interaction with the examiner is also poor. In case of vital signs, the temperature is normal, respiratory rate is around 22 per minute, heart rate is 110 per minute, BP is 109/62, and the saturation is 97, and glucose is 136 milligram per deciliter. In head-to-toe examination, the child had broad forehead, a mild upslanting palpebral fissure, upturned knees, smooth philtrum. The trunk and upper limb was normal. Lower limb has calf muscle hypertrophy. There is a tendinoculus contraction on both sides. The spine was normal and there was no neurocutaneous marker. The anthropometry, the weight, height, and head circumference of the child are within normal limits. On systemic examination, nervous system, the child was conscious, irritable, has sustained eye contact and clings to mother. The child has nil speech. It screams if the child is agitated, and the cranial nerve examination is also normal. In case of motor system, bulk, there was no asymmetry, but there was calf muscle hypertrophy on both sides. In tone, the upper limb tone was normal, and there is increased tone in bilateral lower limbs. In power, the upper limb has normal 5/5 power. In lower limb, the bilateral, there was 4/5 power. And there was contraction of both tendo-Achilles and bilateral popliteal fossa tightness was there. In reflexes, in superficial reflex, abdominal and thoracic reflex was present, but plantar reflex was absent in both sides. In deep reflexes, biceps supinata and triceps jaw jerk are brisk, whereas knee and ankle jerk are sluggish on both sides. Cerebellar examination, the child has equinus gait and has no involuntary movements. The sensory system examination was also normal. Other system examination, CVS, RS, and abdominal examination was normal. Summary, a 3 or 10 months old male autism spectrum disorder child presenting with persistent toe walking with provisional diagnosis of paraparesis and bilateral tendo-Achilles contracture. Investigations, the MRI brain, MRI and MRV was done, which was normal, and MRI whole spine scanning was done, which showed a non-enhancing cystic lesion with CSF signal with no perceptible wall in the dorsal aspect of the upper thoracic spinal canal possibly in the intradural location at D1 to D6 vertebral levels, likely an intraspinal arachnoid cyst. And there was no significant contrast enhancement. There was most effect over the thoracic spinal cord, causing mild to moderate anteroposterior compression with no significant intramedullary T2 hyperintense signal. The image shows a cyst in the dorsal D1 to D6 aspect of the spinal cord. It shows axial section of the spinal intraspinal arachnoid cyst. Diagnosis: intraspinal arachnoid cyst, mass effect on the spinal cord, paraparesis, and bilateral tendinoculus contracture. Course in the hospital: informed consent was obtained and T2 to T5 hemilaminectomy with arachnoid cyst excision was done by senior consultant neurosurgeon Dr. Agipsa. Under general anesthesia, the child was placed in prone position and T1 to T5 level was marked under C arm. The incision was deepened and retraction of lamina was done on one side. And T1 to T6 left hemilaminectomy was done and dura mater was open and the arachnoid is excised and cyst wall is removed around and the CSF flow post cyst excision is shown. Complete hemostasis is attained and the dura mater is closed with ethanol and the surgical glue is applied and the drain tube was kept and the skin was closed in layers. Post-operative course: below-knee cast was applied. The child was started on IV antibiotics injection piptas and epidural drain collection was monitored and replaced. On post-operative day 6, the child had altered sensorium, fever spikes for which the child was evaluated. The baseline investigations done showed an increased WBC count with a neutrophilic predominance. The hemoglobin and platelets were within normal limits and the CRP was negative. The epidural drain was removed and in view of suspected meningitis, lumbar puncture and CSF analysis was done, which showed CSF cell total count of 100 cells per millimeter cube with 50% lymphocytes, 42% polymorphs and 8% monocytes. The CSF sugar is normal, but the CSF protein is raised of 69 mg per deciliter. CSF chloride is normal. CSF gram stain, AFB stain, TrueNAT MTB and meningoencephalitic panel were negative. In view of suspected meningitis, pediatric neurologist opinion was obtained and antibiotics was escalated to injection meropenem. The sensorium of the child was improved and the IV antibiotics were continued for total 14 days. The physiotherapy is done for muscle strengthening and the child was mobilized with a below-knee cast. He was able to bend the knee, rise to standing position. He could walk with heel touching the floor. Below-knee cast was removed after 2 weeks and special footwear was prescribed to help with the contractures. At discharge, the child was able to mobilize with support and bend the knees. Speech therapist opinion was obtained and speech and language evaluation was prescribed after discharge. Arachnoid cyst. The prevalence of arachnoid cyst in children is 1 to 3%. They are more frequent in boys. They can be located intracranially or in the spine. Spinal arachnoid cyst. Spinal arachnoid cysts are relatively rare, accounting for 1% of all spinal tumors. They are benign lesions of the spinal cord and an uncommon etiology of spinal cord compression. They are predominantly seen in the thoracic region. The spinal arachnoid cysts can be classified taking into account whether they are extra or intradural in location and based on nerve root involvement. Location. The spinal arachnoid cysts can be either extra or intramedullary lesions and they can be either communicating or non-communicating with the CSF space. Etiology. The etiology of the cyst is not definitely determined. The primary intradural arachnoid cyst can be idiopathic. Secondary cyst can be due to trauma, postoperative complication, lumbar puncture, infections, or inflammation. Clinical features include pain, lower extremity weakness, gait instability, and spasticity, which are seen in this child. And other symptoms are sensory loss and bladder dysfunction. Diagnosis. The diagnosis is centered on imaging evaluation with MRI and CT myelography. MRI with contrast is effective as initial modality in diagnosing the arachnoid cyst. MRI is also useful to determine the anatomical relationship of the cyst with the surrounding structure. Management. Treatment is centered on decompression of the spinal cord via laminectomy or laminoplasty, followed by resection or fenestration of the cyst. Preoperative symptoms of neuropathic pain and weakness are more likely to be improved than sensory losses after surgical removal of the intradural spinal arachnoid cyst. Conclusion. Persistent toe walking and paraparesis is not a feature of autism. It warrants MRI of brain and spine. Arachnoid cyst is a rare and incidental finding. Arachnoid cyst causing cord compression is extremely rare but warrants neurosurgical intervention. Thank you.
Thank you, sir. This is Dr. Prada, Senior Consultant Pediatrician from Dr. Kamakshi. We wanted to present this case to highlight the importance of the clinical examination. This child was predominantly referred to as autistic spectrum. Until we examined the CNS totally, we found that the tendon Achilles was very contracted and there's spasticity in the lower limbs. And that's how when we started looking for an organic cause. Today we also have our neurosurgeon, Dr. Akib sir, with us, sir, who's here to give his views on the same case. Dr. Akib sir?
Yeah. Very good afternoon. Any questions, sir? Can you see me? Hello.
Yes, sir, you're visible, sir. We're able to hear you, sir.
Yes. So now, regarding this case, normally when we see an arachnoid cyst, we don't operate on the patient very soon. But this case was particularly very different. The arachnoid cyst was pretty big and was occupying the whole spinal cord. So what we decided is that why don't we give a try on the patient? What we did was a small hemilaminectomy followed by complete excision of the arachnoid cyst. And followed by day 2 or day 3, the patient got good improvement and the behavioral changes also appeared. This case is actually very rare in the sense that normally arachnoid cyst doesn't cause any much trouble. But the tiptoe walking and the behavior abnormalities are directly involved to CSF obstruction and corticospinal tract compression causing all this issue. So we have done surgery for this patient. The take-home message on this case will be that all arachnoids should not be treated in a medical management, and surgical aspect do improve patient behavior as well as spasticity in limbs. Thank you.
Thank you for entertaining us the rare case, sir. It's a nice presentation. Any questions from the forum?
What about the speech regression? How can you explain that?
Yes, sir. That is a part of the socio-cognitive disorder only, sir. But we took the EEG, thinking of many other syndromes also. EEG was normal, no seizures. Is on follow-up now. We are working on the speech.
Okay. And
That doesn't explain the yes, the arachnoid doesn't explain the speech regression.
Considering the location of the lesion, one would expect UMN signs to predominate lower down. But here you're getting absence of plantar, and you're getting, of course, I can think that the tendo-Achilles contracture could have contributed to, absence of ankle reflex. But I would have expected UMN signs and other sensory abnormalities to come up. Were they there in this patient?
Sir, regarding the sensory abnormalities, it's a non-verbal child, sir, and we were not able to elicit it properly. But yes, we did the limited sensory examination which we were able to do. We were not able to elicit any sensory abnormalities.
Okay.
Thank you.
Thank you. The contractures were there for quite a long time, right? The child is 3 years, 10 months around. But after surgery, does this contraction didn't require any treatment? I didn't understand because there were huge contraction kind of thing. But after surgery, you said the child can able to walk without tiptoe walking. So, was there any surgery done for this contraction?
No, it's a very good question, sir. The thing is that we actually planned on table to do a tender Achilles release. So then the orthopedician was suggesting to give. Hello. Then what we decided is that why don't we give a POP, do a flexion manually, wait for some time. Then he underwent we gave him a boot For that, he can maintain the flexion in the foot. For that, he developed recovery, sir. We didn't take him for surgery.
Oh. If there are no further questions, we go to the next presentation from Paediatric Medical College. By Dr. Sherry and moderated by Professor Nirinaru. Paediatric Medical College. Over to you.
Good afternoon to one and all present here. Am I audible, sir?
Yes, ma'am.
Slides are
No. Share your screen.
Is it visible, sir?
Yes, doctor.
Good afternoon to one and all. Good afternoon to one and all present here. I'm Dr. Shirin Fatima, a second year postgraduate from the Department of Paediatrics, Sri Balaji Medical College and Hospital. And my moderator is Dr. Sundari ma'am, I'm HOD and Professor of Department of Paediatrics. So I'm going to present about Through the Eyes Lies the Clue, a diagnostic journey. So it's a 12-year-old boy who was referred from the Optal OPD with complaints of stereotypical repetitive movements of all four limbs and frequent eye blinking for the last 1 year, which was initially occasional with 4 to 5 jerks per month, but increased over the past 3 weeks. And he
Slides
had
are
also
not moving, doctor. Slides are not moving, doctor.
Is it okay, sir?
Yes. Yeah.
He also had defective vision of both eyes, which was gradual since 4 years of age, and mother noticed that the child's height was short compared to the younger sibling. He had no history of loss of consciousness, headache, altered sensorium, no history of blurring of vision, eye pain, photophobia, diplopia, no history of lethargy, constipation, weight gain, or cold intolerance, no history of any chronic drug usage, no history of trauma or any bleeding manifestations. So the past history, at 8 months of age, he was hospitalized for viral fever. At 4 years of age, he was unable to see the blackboard clearly, and he was found to have a power of -2 and was prescribed glasses. Antenatal history, mother was hypothyroid during pregnancy and was on tablet thyroxine, which she stopped past 6 years. Birth history was uneventful. Developmental history, appropriate for age, he goes to class 7 with average scholastic performance. Family history is first born to a third-degree consanguineous marriage, no other significant family history. Diet history, he takes a mixed diet with a deficit of calorie of 200 and 8 gram of protein. Immunization history, immunized up to age as per national immunization schedule. Socioeconomic class belongs to upper middle class according to modified Kupusamy scale. And there was no history of any contact. On examination, he was conscious, oriented to time, place, and person. No PLR, icterus, cyanosis, clubbing, lymphadenopathy. Vitals were stable. On anthropometry, his weight was 26.8 kgs, which comes between 3rd to 10th centile. Height was 130 centimeter, which comes below the 3rd centile. And BMI was 15.62, which is between 10th to 25th centile. His circumference was normal, and his upper segment, lower segment ratio was also normal. Arm span was less than his height, and Tanner stage was 2. It comes under proportionate short stage. So head to toe examination. In skin, a single well-defined hyperkeratotic gray-colored verrucous papule of size 0.8 centimeter was present over the extensor surface of left elbow, which is non-tender and no erythema or discharge. Eyes were normal. Nose, ears, mouth, and neck was also normal. Hands had brachydactyly with stubby fingers with short metacarpals. Genitals are soft, reducible, non-tender, right scrotal swelling of size 3 into 2 centimeter with an expansive cough impulse with negative trans elimination test. This is a picture of the brachydactyly. Systemic examination, CNS examination, higher mental function, memory, language were all normal. On cranial nerve examination, visual acuity was found to be 6/36 in right eye and 6/16 in left eye, which is high myopic, and color vision was normal. Motor, spinal cranium, and sensory examination was normal, and other cranial nerve examination were also normal. Other system examination were normal. So the case summary, it's a 12-year-old boy who is developmentally normal child, first born to third-degree consanguineous marriage, had stereotypical repetitive movements of all four limbs with frequent eye blinking, pyretic disorder, defective vision in both the eyes with visual acuity was 6/36 in right eye and 6/16 in left eye, height shorter compared to a younger sibling with height centile of less than third centile, which corresponds to proportionate short stature. Brachydactyly and right inguinoscrotal hernia was also present. So this is the video of the stereotypical movements. So investigations, all the baseline investigations, CBC, RFT, electrolytes, LFT, calcium, magnesium, phosphorus, TFT, urine routine were all found to be normal. Ultrasound abdomen and scrotum revealed right inguinoscrotal hernia. Echo was done and it had no abnormality detected. EEG and MRI brain was also normal. So the course in the hospital, ophthalmology evaluation showed bilateral high myopia, -12D in the right eye and -14D in the left eye, with superior-nasal subluxation of the crystalline lens. Lamellar dots sign was observed on the slit lamp examination, which is suggestive of microspherophakia. Visual field testing revealed inferior arcuate and superior saidal scotoma in the right eye and double arcuate scotoma in the left eye. Optic disc evaluation showed early glaucomatous changes with enlarged cup disc ratio and myopic disc pallor, though intraocular pressure remained within normal limits. This is a fundus picture, and this is the superior nasal subluxation of the lens picture. And this is a visual field effects image, right eye and the left eye. Neurology evaluation revealed no focal neurological deficit and advised EEG, MRI brain and metabolic parameters. Everything was found to be within normal limits and it was diagnosed as benign motor tics. Endocrinology opinion was sorted and it revealed normal variant short stature and advised growth monitoring and nutrition optimization. Growth hormone therapy was not indicated at present. Other evaluations like psychiatry, they reveal normal cognitive and emotional profile. Cardiology opinion was obtained and they revealed stable cardiac status. Pediatric surgery opinion was obtained and they advised surgery for the right inguinoscrotal hernia, and dermatology opinion was obtained in view of the verruca vulgaris of the right elbow, and they advised radiofrequency ablation. And a whole exome sequence was done, and patient was likely to be pathogenic of Adam TS17 variant, which is Weil-Marchesani syndrome 4, and heterozygous for a pathogenic NR2E3 variant, and no pathogenic variants found in the ACMG list. So the treatment given for ophthal, we managed conservatively with spectacle correction for a refractive error. Topical dorzolamide and timolol 0.5% eye drops were prescribed for the lens-induced glaucoma. Regular follow-up with slit lamp and intraocular pressure monitoring was advised to follow up glaucoma. Avoidance of ocular trauma and pupillary dilation emphasized due to lens instability. For neurology, risperidone 0.75 mg per day and clonazepam 0.5 mg HS was started and it showed marked improvement in the tic frequency. For the right inguinoscrotal hernia, pediatric surgery, advised surgery, and surgery was done. Post-operative follow-up was satisfactory, no recurrence noted. And for verruca vulgaris, radiofrequency ablation was done and with complete healing as dermatology. So the discussion. So Weil-Marchesani syndrome, also known as spherophakia, brachymorphia syndrome, and mesodermal dysmorphodystrophy, is an inherited connective tissue disorder characterized by abnormalities of the lens of the eye, secondary glaucoma, short stature, brachydactyly, joint stiffness, and cardiovascular defects. A homozygous mutation in the ADAM-TS10 gene causes type 1. A mutation in the FPN1 gene causes type 2. And a mutation in the LTBP2 causes type 3. And type 4 is caused by the mutation in the ADAMTS17. So 1, 3, and 4 are inherited as an autosomal recessive, and type 2 is dominant. The prevalence is estimated to be 1 in case of 1 lakh in population. Pathophysiology, ADAMTS17, it's a zinc metalloprotease. It partners with the fibrillin 1 to regulate the microfibril formation and extracellular matrix stability. Mutations in the ADAMTS17 disrupt the proteoglycan processing and fibrillin biogenesis, weakening zonular fibers that suspend the lens. So the zonular weakness will lead to the lens mobility, causing microspherophakia, myopia, pupillary block, and anterior lens dislocation. Impact fibrillin function also affects the connective tissues, explaining the short stature, joint stiffness, and systemic features of the Weil-Marchesani syndrome. Thus, ADAMTS17 defects mirror FPN1 dysfunction, linking enzymatic processing failure to the pathogenesis of Weil-Marchesani syndrome type 4. So the differential diagnoses are ectopia lentis, which has only the subluxation with no systemic features, homocystinuria, which has the inferonasal lens dislocation, but the systemic features will be tall at the intellectual delay. But in our case, the intellect was normal and he was short. Marfan syndrome, there is superotemporal lens subluxation with tall stature, long limbs, and aortic root dilation, which is opposite to the Weil-Marchesani syndrome. So the clinical features of the Weil-Marchesani syndrome in ocular, the onset is in childhood, approximately 7 years, with micropherophakia, high myopia, ectopia lentis, narrow anterior chamber, secondary glaucoma, and increased corneal thickness. May have severe myopia without myopic retinopathy. In systemic, there may be short stature, brachydactyly, thickened skin, joint stiffness, and pseudomuscular habitus. There may be cardiac anomalies like PDA, pulmonary stenosis, thoracic aortic aneurysm, cervical artery dissection, or prolonged QT interval. In skeletal radiographs, you may find short and long bones, broad proximal phalanges, and delayed bone age. So the definitive diagnosis is only by exome sequencing or comprehensive genomic testing, which helps to differentiate from the other connective tissue disorders. Ophthalmoscopic examination and anterior segment OCT can aid in the identifying lens shape and position abnormalities. So the treatment is on ophthalmic management, annual evaluation for the patient and the family members for early detection, should avoid myotics and mydriatics to prevent pupillary blockage. Early lens extraction, if microspherophakia present, causes visual deterioration or raised IOP. Glaucoma glaucoma management is peripheral iridectomy or trabeculectomy as indicated. Consider corneal pachymetry correction while monitoring intraocular pressure. So the systemic management, regular growth and joint assessment with physiotherapy for stiffness if needed, cardiac screening, echo or ECG for valvular anomalies, genetic counseling for family risk assessment and carrier testing. So the prognosis is variable but favorable with early detection and multidisciplinary management. Visual outcome improves with timely ocular intervention and glaucoma control. So the conclusion, Weil-Marchesani syndrome, though rare, may present subtly with growth, ocular and skeletal abnormalities. Careful observation and genetic confirmation establish the diagnosis. Early detection and multidisciplinary care are key to preventing visual and systemic complications, which reinforces that thorough pediatric evaluation bridges clinical clues with genetic diagnosis. So the take-home message is, think a syndrome in a child presents with short stature and high myopia. Early ophthalmologic evaluation can prevent irreversible visual loss. Genetic testing confirms diagnosis and aids family counseling. Multidisciplinary management is essential for optimal outcomes. Remember, small stature can carry big clues. Look beyond the obvious. These are my references. Thank you.
Good afternoon, everyone. I am Dr. Ramya, professor from the Department of Pediatrics. I appreciate the speaker first for an excellent presentation. And this case is being presented mainly for two reasons. One, for its rarity, and the second one is to reinforce the importance of clinical examination. The main clue which led to the diagnosis was the eye finding. So, our HOD sir, Department of Ophthalmology, Chandrasekharan sir, gave the primary diagnosis as Weil-Marchesani syndrome right after examining the child, and we only did the genetic study to confirm the diagnosis. Now I invite Dr. Chandrasekharan sir to share his views.
This case came to our OPD for diminished vision. When I examined the child was having only 2 meters vision and he was very short, having not connected.
Just share the screen, share the screen.
Sorry for the interruption. This child, when he came to our OPD, he was having diminished vision of 2 meters only. And then he was having a short stature with joint stiffness, and he was having short stubby fingers. Apart from that, he was having some involuntary movements in the hand. So we subjected him for all the usual routine ophthalmic examination. And we found that there is a displacement of the lens. This displacement of the lens, we call it as ectopia lentis. So when I saw him, it was a spherophakia. The lens was pushed inferiorly, inferonasal. And not only that, whenever a child like this, with short stature and short stubby fingers, sometimes we see webbing of the neck also. He is not having any webbing of the neck. And there is no mental handicap was not there. He was studying some 7th standard or something. So then I asked, doing the routine things, we found the intraocular pressure was high. And not only that, we did a thorough examination for glaucoma. The AC was moderate, irregular because there is an infranasal subluxation of the lens. We must know what is subluxation and what is dislocation. Subluxation means if a portion of the lens is seen in the pupillary area, we call it as subluxation. And if the lens is not at all seen in the patellar fossa, we call it as dislocation. So this type of infranasal subluxation with the morphological features of short stature and stiff joints and short stubby fingers, we thought it can be Weil-Marchesani syndrome. Then when we saw his fundus, the fundus, he was having severe myopic changes. Not only myopic changes, he had laminar dot sign. That is, there is a thinning of the neuroretinal ring superiorly and inferiorly. And we saw the pores of the optic nerve. That is, centrally, where the cup is there, we see a lot of gray markings. So this we call it as laminar dot sign. So the child was having glaucoma for a very long time, and the intraocular pressure was high. Then we did the routine OCT and other tests for glaucoma, and we have confirmed there is a thinning of the RNLF layer. RNLF layer was thin, and the child was having glaucomatous changes. So sometimes people miss treating only the myopia, and they may forget about the glaucoma. So the child has got both glaucoma as well as myopia. So the child, even though the child had -12 and -10, we gave -7 for the right eye and -8 with one cylinder for the left eye, and he was improving to 6. And the child need not undergo any surgery right now. What is the indication for removal of this subluxated lens? So whenever the lens becomes cataractous, or if the glaucoma is becoming refractory, if it is not at all getting controlled, so then if the child has got diplopia, so these are the 3 occasions where we try to meddle with the lens. That is diplopia, refractory glaucoma, and lens becoming cataractous. So these are the occasions where we try to remove the lens and put a intraocular lens. So right now the child is under surveillance and his intraocular pressure is being checked regularly, and the child's vision also is doing with the 6/9 with the glasses prescribed. So this is a very rare case. We call this as Wien-Marchesani syndrome, and we referred the case to our pediatric department, and they have found out the genetic study was also coinciding with that, and the genetic study totally proved it is only Wien-Marchesani syndrome.
Thank you.
Thank you, sir. Thank you for your sharing the experience, sir. It was a nice presentation. I'm well evaluated. Any questions to the forum?
I would like to thank my HOD and Professor Dr. Sundari ma'am, Professor Dr. Ramya ma'am, and HOD and Professor of Ophthalmology Dr. Chandrasekharan sir for guiding me with this presentation. Thank you.
Any questions to the forum?
I think well presented, sir. I think with this take-home point, they can go for publication. It's a rare case, so they should present it. Thank you, sir. Thank you, Dr. Rajkumar, sir, for organizing.
Thank you for all the participating colleges for the wonderful presentation. The active motivation. Thank you, sir. Thank you.
Thank you, sir. Thank you.
Yeah.
Very useful. Every question you are up to rule out. Sir, pen drive எங்க சார்? எடுத்துட்டு வா.
I don't want to think. அப்படியே பாத்துக்கோ.
Don't want to think. Brain அப்படியே வெச்சுக்க.
ரீல்ல பார்த்தா நீயே பேசுன மாதிரி தான் இருந்துச்சு. ஆனா அதான் கம்ப்யூட்டர்ல தெரியல வரல. கொஞ்சம் மறந்துட்டேன். அப்பப்போ இப்படின்னு மட்டும் தெரிஞ்சுது. இதெல்லாம் தான் தெரியுது. இவங்க அவர் பின்னாடி தலையில வந்து கையடிச்சிருங்க போட்டோ எடுக்கணும். அட சும்மா தியாகம் நான் போட்டோ எடுக்கணுமா? இந்த பொண்ணு என்ன விட்டு ஓடி வந்துருச்சு. மேம் நீங்க இல்லவே இல்ல ஓபில நீங்க எனக்கு போட்டு நினைச்சேன். நீ பார்த்த நான் பார்த்தப்ப இல்லையே அறிகரவே இல்ல டிஸ்கஸ் பண்ணிட்டேன். நான் எனக்கு தெரியவே தெரியாது. திருப்பி பார்த்தா யாருமே
இல்ல ரம்யா மேம் வர சொன்னா ஹரிஹரன் நீங்க.
ஃபர்ஸ்ட் இயர் தான உட்கார்ந்தது நம்ம மூவி கொடுத்து அது